It's going to go downhill from now, it's the introduction like that. I know, with such this high energy introduction. So I go home yesterday evening. No, it's not an Ashton Kutcher story, those who are looking for it. And I have this beautiful floral arrangement with a very gracious thank you note on behalf of the mHealth team, a group, yes. And I've said before, my wife and I enjoyed having you. The pleasure was all ours. You shouldn't have done it. But having received it, I was very touched by the old school gesture in a world of Instagram and emails to actually get a gracious note. It only reemphasized to me what a classy group you are. So thank you again. And let's move on to this morning's presentation. So I'll be talking about point of care testing, and if my colleague Idogan shows up, we will be covering a different spectrum of the mobile health universe. Unlike the sensors that Santosh and Jim talked about that provide high-dimensional data and then, with ferreting out signal from all that noise in the background, the point-of-care testing technologies, biosensors in particular, ferret out, the signal directly, and I'll speak to that in a moment. But before that, let me just acknowledge I have been worshiping at the altar of NIH for many years, and successfully. So I want to acknowledge all the gods and goddesses who have bestowed me with funding to do some of the stuff that I will be speaking about. And the other is my research team. I don't want to take, I want to give credit to all the smart people I surround myself. I found early in my career that if I surround myself with smart, good-looking people, then, vicariously I could pretend to be like them. So I have derived from wonderful brains. You met David Ellishoff, Tom Bellin, my statistician, Grant Marshall at RAND, Ted Robles in psychology, and wonderful grad students, Corey Ziegler, now he's an assistant professor in biostat at Harvard, and Lauren, and one in the making, Jason back there. So it's kind of a reflection of all the people on whose shoulders I stand as I speak to you today. So my talk really will have three themes driven by Wendy's boundary conditions. I will be talking about the boundary guiding principles of point-of-care technologies, which essentially is technologies that allow patient care, that give diagnostic results at the point of patient care. I will introduce you to some key terms, so whenever you deal with someone working in the space of point-of-care technologies, you understand where they're coming from and what are some of the common terms used from them. And finally, through a case study, through one of my research themes, kind of walk you how these issues evolve, how the need for point-of technologies actually the need develops, why you should be working with me, for someone like me, not just because of the Indian dinners, but also because hopefully there are more compelling reasons than that. And finally, what is the kind of relationships I look for? And hopefully that will manifest in my description of the study. So what is it, what drives this whole discipline of point-of-care technology? We talked about about healthcare being increasingly, the need for it to be increasingly patient-centric. And with point-of-care technologies, I would say it is also provider-centric, and I'll explain that in a moment. Now, the changes that are happening as we move away from testing that is done in the hospital. Remember, we often forget that large segments of our society have very severe access to care issues. It's not easy for that lady who is living in South Central LA to take multiple buses to come to this ivory tower that's the UCLA Medical Center. So there are huge access to care barriers. And it has been downshifting from hospital settings to specialty labs to outpatient clinics. And that now increasingly is going to involve places like Walmart and Walgreens, where testing will be done. And moving out into the community, going to places where there is a need for these services. And finally, at some point, there will be these kind of technologies that will be available in the homes, and we will be monitoring patients in their own homes, in their own environments. Now, I think the biggest need and the highest value proposition is in resource-poor settings. Healthcare systems fail, and they fail terribly and horribly in places that are bereft of resources, particularly as you go towards the developing countries. Often resource poor means really they may not even have water, they may not even have electricity. So it's under those conditions that the true highest value proposition manifests itself. So there is point of care testing that takes place in the hospital, in the intensive care unit, but when we talk point of care testing, we are talking more about at the individual level and the community level. So that will be the thread of my talk. When the patient comes to the healthcare provider, it's essentially that person is a black box. You do a series of, you do the historical, you take the medical history of that person, they give the signs, symptoms, and you have this kind of working diagnosis. To clarify, often then you take a sample, take a blood draw or a biofluid, and then the most compelling reason for point-of-care technologies is the immediacy of the result. And more importantly, it eliminates a whole bunch of pre and post processing errors. Take, for example, the drawing of blood, which is probably the one that most of us are familiar with. You need specialized personnel, you need phlebotomists who do that. The specimen collected has to be handled, and there is always the danger of contamination. And at some point, then it is transported to the centralized lab. And at that point, again, there is this degradation that comes in place if it is not properly preserved. And of course, the specimen can get lost, as we know. And then at some point, it reaches the specialized lab. In the specialized lab, there is obviously, these are very resource-intensive places, and with very expensive equipment, highly trained personnel. All those personnel costs need to be handled. And then there is a mishandling that can happen at this level. And so at some point, the results get generated, and again, there could be a misreporting, and then finally, results can be lost, and that happens. And at some point, that result makes its way back to the care provider. Now, this brings us to who then makes a therapeutic decision. Now, typically, that kind of therapeutic turnaround time, that's the key word, can be hours, but mostly it is days and weeks. And that is a tremendous loss of waste of resources. And it's so typical of the encounter right now. You go in, your physician or nurse practitioner checks you out, and then does a blood draw, and then at some point, they get access to it, and something gets lost. That's unfortunately the way it is. And this, as I said, is particularly an issue when you are working in resource-poor settings. Consider the possibility of these point-of-care sensors, point-of-care technologies. The whole turnaround time is now minutes. So for example, if you are the care provider, you have 15 minutes, and you can actually have actionable data that allows you to make a very sophisticated, therapeutic decision. As I said, think about it, particularly, say you're in sub-Saharan Africa, say working, screening kids with fever, and you're trying to rule out malaria. And those are decisions you have to make fast. It has very serious complications. And typically, you take for the smear microscopy, you take samples, give it to a courier, sits on a motorcycle, and they go from clinic to clinic, goes to a central lab, and all that is time lost. And so, particularly in those kind of settings, the value of point-of-care technologies is very high. And I see Idogen is here, who's doing some cutting-edge work, and he will be speaking about that in a moment. So, let us not fool ourselves. Point-of-care technology has, testing has been around for a long time. The Greeks, the Indian physicians, the Chinese physicians, many years ago that they were doing the sweetness of urine for diabetics. Now, fortunately for us, we have our engineer colleagues, and that has moved to more sophisticated equipment. No need to stand next to the patient and sample the urine. This is a good time to turn over, give your engineering colleague a hug, okay, if you are seeing us there. So this is a kind of a blood glucose monitor, and that detects glucose in urine. These glucose, monitoring is actually the 800-pound gorilla in point-of-care technologies. About 90%, that and pregnancy tests, about 90% of all point-of-care technologies center around these devices. But having said that, there is all other things that are happening, things like, cardiac, people with chest pain, you want to rule out a myocardial infarct, you go for troponin. So there's a whole bunch of different conditions where these point-of-care technologies are being developed for. So what are some of the key terms that we think about? And I have to be, because there is often different terms mean different things to different people, so let me make a few simplifying approximations. For example, the term biomarkers. When we talk to the people who are doing passive sensing, they're usually looking at heart rate and respiration rate and heart rate variability. Those are also biomarkers. But when we talk about point-of-care technologies, we're talking of either cellular, biochemical, or molecular alterations that are measurable, quantifiable, semi-quantifiable, quantifiable in tissues, most likely, in human cells, mostly biofluids. Okay, so that is a working. And then the biomarkers can actually be grossly classified into biomarkers of exposure or biomarkers of disease. A biomarker of exposure, for example, a good example would be lead exposure. And yes, you can get that sense of the burden from doing a questionnaire from the patient, but more importantly, you can get a direct assessment of the exposure through a testing of their your blood, or the teeth, or even their hair, and then predict the consequences, health consequences of that dose of exposure. There are also the biomarkers of disease, going from the early stage, where you are in the prodromal stage, to a diagnosis of a manifest disease, and even monitoring of the response to therapy. An extension of that is then biosensor. And biosensors are really these little compact integrated analytical devices that are used to detect or measure biomarkers. Now, they are called biosensors because they usually have a biological recognition unit, but not all point-of-care technologies are biosensors. Usually when we say biosensors, we make the assumption that these are these are point-of-care technologies. Now, biosensors, they could come in different forms. There are the larger desktop ones. This is for C-reactive protein that is used, pediatrics and in the ER, for example. Or more importantly, this is by Abbott, that iStat. It's a kind of handheld reader, and you can get, depending on the cartridge you use, get immediate blood chemistry, chem panels, and a whole bunch of analysis at the point of care. So it's very innovative, very enabling technology, and that's where some part of medicine is headed. You'll hear the term nanosensor. Nanosensor are tiny devices, for example, nanowires. Nanowires that may contain nanowires that is, say, 100,000 times thinner than the human hair. And they have exquisite sensitivity, and we'll talk about that in a moment. The other term that you will commonly hear is multiplexing. And multiplexing is not, rather than chasing one single biomarker, you're chasing a whole panel of informative biomarkers and trying to extract information from them. And this, again, is where point-of-care technology is headed to. And finally, the term you'll hear is lab-on-chip. And lab-on-chip is simply something that derives from microelectronics, small, tiny chips, millimeters to centimeters, that contain all the processes of a lab, from processing the biofluid to analyzing it to reporting it. Everything is contained on a chip. And really, it's our very innovative engineers and engineering community that have enabled us to be better at providing care, and it's very exciting times. So in general, this integrated analytic device contains three components that you should be familiar with. One is a recognition element, and what it does, it recognizes, if you're interested in a particular analyte in the biofluid, it recognizes it and creates a change. And that change is then picked up by a transducer that creates an electrical signal, and finally there's an electronic system component to it that cleans out the signal, amplifies it, and processes it. And typically some of the recognition units, mostly in biosensors, they're antibodies and enzymes or nucleic acids. The transducers are electrochemical, they could be optical. You don't necessarily need the biological recognition unit, as you'll find out from Eidogen's talk, and an acoustic. And finally, the electronic system, there is a tiny amplifier to amplify that low-level signal, processors to scrub it out, and then display it. And finally, increasingly as it happens, it's being that those signals are being picked up by acquisition nodes like cell phones and transmitted to central data collection centers where they're integrated with electronic medical records. So there is this, even if the patient is far away and the data is being collected in the field. So a quick, when exposed to the analyte, the biorecognition unit, generates that signal, it's amplified, and then you get a digital readout. The thing that I actually want to point out to you is this is where the analytics comes in. So you're no longer, one theme that I want you to understand is clinicians hate raw data. Their life is busy as it is. So as you as engineers think about it, you want to give them kind of process data. You want to give them actionable data. Just tell them, what does all that mean? And it's the same for the patients. If we want to empower our patients, we have to give them kind of actionable data. That not only is it telling them your high risk, low risk, or your blood value is this, but you're also saying what are the next steps. And this has to be connected to the larger ecosystem of devices. So some of the other characteristics when you develop these biosensors, a fundamental requirement is accuracy. You want to know how close it is to the target. Remember, these biosensors are trying to replicate these very sophisticated lab-based equipment. So you have to keep in mind that, yes, they should be fairly accurate and close to the accuracy of these very elaborate lab devices. However, the context is also very useful. If you're going in a resource-poor setting, there are going to be trade-offs, and you can accept lower accuracy. You can use that device for triage and more sophisticated care. So, but accuracy is kind of one of the more absolute requirements of a biosensor. Obviously, reliability. You want to know that that equipment, measurement equipment, is giving you the same signals every time you use it. There is always a drift in the signal. The ones in the labs, if you don't know, they are being calibrated every day before they do the batches that come in. So that calibration should be something that you need to think about when you are considering biosensors. Obviously, it has to be sensitive enough, and depending on the condition, you want it to be very, very sensitive to pick up those very faint signals that may be there. Selectivity is also a very key requirement. You want the recognition unit to pick up the signal of that particular analyte. This becomes more and more an issue as you go into these multiplexed nanosensors where there's all kinds of contaminants and cross-reactivity with similar molecules. So that is an issue that the engineers, in particular bioengineers, need to be aware of. And finally, the dynamic range, meaning that there are certain blood values for a certain disease condition, and you want to be sure that you are not only the range of your biosensor can capture not only the low and high end, but also the disease values. It can be extremely high or extremely low. So, and inside of that dynamic range, we also have to make sure that there's a kind of a linearity, meaning with increasing concentration of that particular analyte, there's a kind of a linear response of the biosensor. From a practical point, it has to be near real time, not 3 hours and 5 hours or 10 days. It has to be low cost. It has to be affordable. It has to be user-friendly, meaning that anyone with limited training can use it. It has to be portable, meaning hopefully it can be carried around in your hand, and robust, meaning that not only can you use it in a resource-intense setting, but also in sub-Saharan Africa. That means it doesn't have antibodies and all that get denatured if the temperature is too high. So those are some of the thought considerations you should be familiar with. Low cost also is an issue, and it's not just a unit, but it's also the whole infrastructure. If you need trained personnel or you need to refrigerate that biosensor, then suddenly the cost, that cost per unit is deceptive. So that the whole context is also very important. Let me, through my personal example, lead you to how I walked into this world of point-of-care technologies. My interest has been in stress, particularly traumatic stress, and driven by the fact that I worked with people with facial injuries, and I was kind of interested in what happened to them. And also early on, 20 years ago, I was kind of saying, okay, the whole surgical community obsesses about putting bones together, and so yes, Donna. Oh, 3 minutes. I think we began late, correct? 3? Oh, 3 more minutes? Okay, I'll speak fast. So essentially, the focus is on restoring the physical injury, but there are also these mental health sequelae that manifest. So I was interested in what happens to these people after that, and obviously I found in our longitudinal studies a large segment of them, about 20-25%, were manifesting the endorsing symptoms of post-traumatic stress disorder and major depressive disorder even 1 year after the fact. So the challenge was, as happens, is that the stress reactions in the early phase are very subtle. If you're a non-specialist, it's very difficult to find out. And psychiatry and psychology depend a lot upon the DSM. They look at syndromes. There are these symptom clusters that are very bewildering. It's all syndromal. And most importantly, the time and resources in the acute care setting are very limited. The surgical teams have no time to sit down and ask these long questions. So I said, why don't we approach it in a different manner? We know that the traumatic stress elicits a kind of a neuroendocrine response, and those biochemicals that are spewed into our bloodstream, they kind of manifest in blood, in our sweat, in tears, and saliva. So wouldn't it be nice if we came up with devices that kind of help people who ordinarily don't look at this to give them some indicator of this person needs care beyond the physical injury. So my whole effort has been on developing these sensors that can measure, analyze, and report them. Let me skip. So the strategy, in this case, is you have a collector that is disposable, it's low cost, and you collect saliva, and then put it in a reader, and then at the same time we're doing conventional psychometrics, and then mapping it onto those. And then finally, what we do is we create integrative algorithms, and that we can feed back into the CPU of the biosensor. So it's not raw data that you're getting, but also actionable data that tells the nurse or the trauma center, a person that this is a bit, this patient is at high risk of post-traumatic stress disorder. But when you start thinking about it, I needed people with product design, simple things like designing that. I need people who are trauma surgeons who are attuned to, research enterprise. I needed people who are biochemists, people who had competencies in microfluidics, integrated circuits, and rapid prototyping. So you see how complex my universe suddenly gets. And then, then I needed people who were very good in psychometrics, particularly PTSD. And then finally, I needed experimentalists, I need biostatisticians. So really, suddenly you see how multidisciplinary this gets, and you need help from every quarter. And very quickly, I'll walk you through it. This is one of our first salivary amylase, is a surrogate for epinephrine, measures the sympathetic response, and calorimetric. It takes fixed amounts of saliva, small little details. You get every time you put it under the tongue, you get exactly 20 microliters because it saturates with that. And then you get daytime stamps, data storage. It normalizes the pH of saliva and temperature because there are sensors in it. And then what we do is we see how accurate is it. So like I said, we compare it to the standard Olympus in the lab, and this is an example of the very strong correlation we get with the lab-based equipment, and the results within 25 seconds, kind of meets the definition of point of care. The other thing is how reproducible is it? We take saliva samples and then do them at 2 different times. The horizontal is the Olympus, and again, you see there is a drift, and a coefficient of variation of about 8.4%. That's the trade-off. You're giving up the sophistication and the expense of a lab for a small device. There is a measurement variability, and here we do interclass correlation. We find out most of the measurement variability comes from the population which you want. 3% of it comes from the device. So all in all, we're getting good, accurate readings in a reliable manner from the small device. Similarly, developed a salivary cortisol. As you can see now, they're growing larger because the platform is different, kind of a immune sensor type. And then it became clear to me this chasing a single biomarker is not very useful. And 2 minutes. We have, I fall on your feet. Give me 2 minutes. Okay. So cancer antigen 125, as we found out with the PSA, the non-specific, a lot of overdiagnosis. And so decided to go into a kind of a multi-analyte. This is what I'm using in my research, mapping out all the different pathways of the stress response, the sympathetic, and all those different bioindicators. And then I need to go, so okay, we have this panel, what do we do? So I turned to my bioengineers, I've given them a brief, and so the next step is, we started using carbon nanotubes and seeing if we could functionalize them with antibodies that the advantage of this is you can create these high-density arrays and do multiple analytes at the same time. Challenges, there were challenges in fabrication. So more recently, we've moved to field effect transistor technologies using 2D molybdenum disulfides. And this is where I am. So the goal is, you're creating these little inexpensive strips that can detect multiple biomarkers at the same time, and with that, hopefully enable the field of stress in general, but traumatic stress and everything else. Thank you for indulging me. So I'll stop here.